Good morning. It's really a pleasure to see so many amazing people here. I was asked to speak, I think, about the success of PMTCT for HIV prevention, insofar as it serves as a model, both biomedical and programmatic, for treatment as prevention in the heterosexual setting. So I think this audience knows only too well. Approximately 1.5 million HIV-infected women deliver annually, and in 2012, it was estimated that 250,000 children were newly infected with HIV, with nearly 90% of those infections occurring in sub-Saharan Africa. Is way of just very brief review. In the absence of any intervention in a non-breastfeeding population, between 20 and 25% of HIV-exposed infants become infected, and approximately 35 to 40% of breastfed infants become infected. As with heterosexual transmission, the single, by far most important determinant or predictor of mother-to-child transmission is maternal viremia or viral load. And this really shows from a US study the rate of transmission from mother to child depending on maternal viral load. Transmission is exceedingly rare, but still possible with maternal viral load, even less than 50 copies, which is corroborated by a study that just came out as well. But it's as low as 0.09%, and I think we also have to take into account potential viremia earlier that was not measured. Who knows? So as in pregnant women, as in the general population, the burden of maternal mortality and for PMTCT transmission really occurs and is concentrated in those women with CD4 less than or equal to 350, and consequently they have, of course, been over the years a priority focus for treatment and PMTCT. For PMTCT, more potent antiretroviral regimens are associated with lower perinatal transmission. So you can see here again in a non-breastfeeding population in the US, the rates of transmission with regimens of increasing potency with 3-drug ARVs on the right and 1% transmission there. Also, longer antepartum treatment is associated with less transmission. So women who are on HAART at conception are less likely to transmit than women who start HAART during pregnancy. All of this makes sense, but I think, again, it's somewhat analogous to transmission in the sexual setting. So treatment with HAART at conception is associated with a 0.1% transmission in this British study, compared with 1.3% for women who initiate HAART during pregnancy. And this has been shown repeatedly that each additional week of antepartum treatment is associated with reduced MTCT risk. So this is just a graphic of some of the many PMTCT studies that have been conducted in Africa, Thailand, elsewhere. Again, showing on the left 37% transmission in the absence of any antiretrovirals, and 1.1% transmission here in the Botswana study that Max alluded to, the Mabana trial, in which mothers received triple ARV starting in pregnancy and during 6 months of breastfeeding. So in 2009, UNAIDS called for virtual elimination of MTCT by 2015. That is a greater than 90% reduction in transmission, leading to a less than 5% MTCT rate among all HIV-exposed children and a less than 2% MTCT rate in babies who are not breastfed, with more than 90% of women receiving ARVs. So I guess the question is, how well are we doing at implementing this biomedical intervention, which has really quite staggering efficacy? Again, for this audience, I think I need not emphasize the complexity of the care and treatment cascade that HIV-infected women and their infants need to negotiate to receive all of the interventions that are required to reduce MTCT. And this is just a graphic from Elizabeth Stringer earlier on, showing, though, that because of little erosions, drop-offs at every step of the cascade, only 50% of HIV-exposed infants were prophylaxed with antiretrovirals. Obviously, some steps in this cascade can be and have been eliminated, but it's a very complicated endeavor. And really, studies had estimated that elimination of MTCT to reach those targets would require near universal HIV testing and greater than 95% coverage with ARVs. So again, how well are we doing with ARV coverage? This is a graphic from UNAIDS showing ARV coverage between 2005 and 2012 in different regions of the world. Overall, in 2012, 62% of HIV-infected pregnant women received quote-unquote effective ARVs to prevent during pregnancy. So they excluded coverage with single dose of Gaborone alone. And as you can see, the improvement between 2005 and 2012, or lack thereof, varies quite significantly by region. And very encouragingly, the most marked improvement in coverage occurred in Eastern and Southern Africa. And I think we can really highlight Botswana as a shining gem in this regard in terms of its PMTCT program. It was the first country in Africa to provide free nationwide PMTCT starting in 2000 and introduced universal treatment during pregnancy, regardless of CD4 or option B in 2011. And in 2013, from Botswana statistics, 99% of pregnant women tested for HIV, 99%, and 96% of HIV-infected women received ARVs during pregnancy. The vast majority of them 3-drug ARVs, with 5% still receiving AZT only. And the estimated MTCT rate was 2.5%. So I think this is really quite remarkable success. How are we doing in terms, I mentioned a little bit about the coverage globally. How are we doing globally in terms of reducing MTCT, which is ultimately the goal? So again, looking at the decline in MTCT in resource-limited settings between 2009 and 2012, we see a 35% decline in MTCT from them, from 26% to 17% in resource-limited settings, and more than 50% decline since 2001. So good, but you can see down here the little dot is the target MTCT of less than 5% by 2015. So we've got a ways to go. And again, along the same lines, this is just to emphasize that not that it's not possible, but that this highly ambitious goal of achieving less than 5% transmission or virtual elimination will require greater than 90% coverage with ARVs during pregnancy, and 90% alone will not be sufficient at achieving that target. So I think in recognition of the requirement for combination ARVs to optimize maternal health and minimize transmission, as well as even more in a more compelling way to simplify the PMTCT cascade, the WHO in 2013 recommended that all pregnant women, regardless of CD4, receive 3-drug ARVs during pregnancy and breastfeeding. And as a conditional recommendation, recommended lifelong ART, regardless of CD4, and not, so in other words, option B plus, and not a start and stop for women with high CD4. And more than 20 countries are moving towards option B plus. I wanted to highlight the success, I think, of the option B plus rollout in Malawi, which I think is probably the preeminent success in this regard that's been highlighted thus far. So in 2011, Malawi rolled out option B plus. They decentralized treatment, added facilities, trained nearly 5,000 healthcare workers, task shifted ART start, and didn't do labs. And in the context of introducing this 1 year after implementation, they increased the percentage of women, the number of women starting treatment, antiretroviral treatment during pregnancy increased 7.5-fold, which is really quite amazing. And nearly 90% of all known HIV positive women were on treatment. Interestingly, in a sub-study, approximately 15% of women declined to start treatment, even though it was offered to them, with fears around disclosure, side effects, and religious reasons being cited. A note of caution, perhaps, from this rollout in Malawi was that 1 year after starting treatment, 77% of women were known to still be on treatment, 23% were not, and the vast majority of those who were not known to be on treatment had been lost to follow-up. So in summary, I would say that PMTCT represents a remarkable biomedical and programmatic success, despite remaining challenges even in the PMTCT realm. There are some differences, and this is obviously not an exhaustive list, but there are, I think, some notable differences between PMTCT treatment as prevention in the PMTCT arena versus treatment as prevention for reducing sexual transmission. First, I think that women and families are perhaps even more highly motivated to adopt treatment in order to protect their baby. I'm not sure there are good data on that, but I think that's potentially true. Option B, not option B plus, but option B does not require the lifelong commitment of the mother to antiretroviral treatment, and that may be different than treatment as prevention, at least insofar as we're messaging it that way. However, ART for PMTCT carries some challenges that treatment as prevention for heterosexual transmission does not. There's just an urgency to start ARVs as soon as possible during pregnancy, which is even more important. There is often fractured care between the antenatal care setting and the treatment setting, and there's the need to prophylax and test and follow up the baby and the issues around infant feeding. So I would submit that PMTCT can help inform our TASP efforts, but does provide reason for cautious optimism that TASP can achieve the high coverage rates required or that we're aiming for. Thanks.